So we're going to take a few minutes. Anybody who has a question, please go to there are microphones in the middle of the room. So I do want to kind of open this up. Alex, did you want to open it up? You had?
Yeah, no, I have a question to George, since it's
sure.
a hot topic that
Yeah,
just presented. So George, two questions for you. The first one, do you think that this is going to be a class effect with rivaroxaban, apixaban, and other drugs? So that's the first one. And then the second one, when you diagnose HALT, or when you know that there is leaflet thrombosis, which will be your first option? Vitamin K, anticoagulant, or NOAC?
Well, this is an interesting question. In general, these drugs work kind of the same way, so I would be very surprised if it's not exactly related to the class and to the dose. Most of these drugs have many doses as well, so we have to be attentive to the dose more so than anything else here. I think that it's in general there's a class effect that we've got to be careful, but we can alter and play maybe with lower doses, and then we may get also good efficacy. I think it's very important to know that the efficacy is good with lower dose. So I would favor a lower dose if there is a diagnosed HALT. I don't know why there would be diagnosed HALT. I don't know for what reason this is done. And that is something to be discussed. I didn't show you the slides of that Raj presented at TCT in Partner 3 trial. Turns out that quite a few patients with surgical valves also had this phenomenon up to 1 year, about something like 15% or so. So Raj, would you agree that, at this point, I don't know who might be identified, because I just see that a lot of these CTAs and all that would be not performed. So it's a little bit of a puzzle, but if someone has a clot, I definitely don't like that. I'd like to do something about it.
Yeah, so I think I want to make an important point that outside of research protocols or outside of a clinical situation that warrants ruling out valve thrombosis, there is no role for systematic 30-day CTs. We are doing those at Cedars as a part of a research protocol because we are trying to understand the history of this. Number two, I think, what do you do if you have it, right? So I think what we found in the serial CT studies in the Partner 3 CT sub-study was at 30 days and 1 year was that half of the patients who actually had HALT at 30 days did not have HALT at 1 year. But equally, so that was, that is a good thing. But what is a bad thing is that 20% of the patients who did not have HALT at 30 days actually had HALT and reduced leaflet motion. So you can't just say that this goes away. So it may go away in some, but a new finding comes in a lot more patients. So the total frequency of this finding actually goes up from 10% at 30 days to 24%. So 1 out of 4 patients with bioprosthetic valves actually has has this finding at 1 year.
Is it fair to say that we really don't have data of the association of this finding to clear-cut poor outcomes? Can we say that? Because I think it's really important, because even if we see it, we don't know what to do with it. Is it associated with degeneration, earlier degeneration? Is it associated with stroke, death, MI, whatever? You want to tell us?
So what we know is that it is not associated with death, stroke, or MI. And that is also because of the smaller sample sizes of the smaller studies. Yeah. In the study that we had in the Lancet, where we had almost 900 patients, when you pool events, you see a clear association with TIAs and strokes. So when you start pooling them, and retinal artery occlusion, and we see that signal also in the Partner 3 CT sub-study. And the follow-up is only for a year, right? So you need longer-term follow-up. The gradients go up by about 4 to 5 millimeters of mercury in patients who have HALT both at 30 days and at 1 year. So what will happen at long-term follow-up needs to be seen. But interestingly, there are actually studies where thrombus, in specimens where there is thrombus, there is also positive sodium fluoride scans, which represent microcalcification. So this is, but we need to wait and see what happens at long term.
Well, I think it's fair enough to say that this is an area of really unclear understanding of what to do. And to me, I find this to be extremely urgent, given that we're now expanding TAVR to even low-risk patients where we absolutely must know what to do. And I think there's a very quiet sense in the community that, oh, it's okay, well, whatever you do, it's okay, we're still getting great results. And I would say, please, no, I don't think we can go in that direction. Can we close that with the last statements from you guys? Because I
Yeah,
want to...
well, I'm going to say that I can't imagine that this doesn't matter in the durability. The fact that we don't have that kind of data yet, this doesn't mean we know there's no problem. What we have resolved in some ways is that it is not a major problem of an imminent stroke or an imminent MI or an imminent major event over the few months of the first year. We talk about the durability. Think about it. If your door is squeaky, nothing good is going to happen 3, 4, 5 years down, unless you oil that door a little bit and get rid of the squeakiness. I mean, I think this goes without saying in my mind, and it's just a matter of time and data to show it.
With that scientific statement, we're gonna go now. No, it's pretty important, and I think it's great. And we're gonna take a 15-minute break. I want everyone back here at 11:20. Dr. Dangus will preside and will take over from me. Thank you all. It's been a great, great morning. Thank you. Please visit exhibits. Say hello to the exhibitors who support us. Thank you.